on the altered cardiovascular function slides. This is slide 14. Slide 14. Okay. And what I'm going to do is really look at summary points in relation to heart failure. Okay. So we know that heart rate and stroke volume determine cardiac output or perfusion. Heart rate affected by the autonomic nervous system. You've got your SAAV, Purkinje fibers, your nodes. And we also know that stroke volume is affected by what is called preload, afterload, and contractility. And when you look at that, you're basically looking at the stretch on the ventricle at end diastole on the right and the left side. So now we were talking about, remember, our heart failure patient is the stretched rubber band. We no longer have that taut pump, myocardium, that pumps all that blood out and then therefore all that blood comes back. We don't have that. We have this. We have the stretched rubber band. So we know there's less blood flow coming back to the heart and less blood flow going out. So what happens is we know that the heart rate will increase. The brain sends a message to the heart where you've got to increase your rate. And the kidneys are then going, well, I'm not getting what I need. So I'm going to release renin, angiotensin, aldosterone. And that's a compensatory mechanism to that decreased perfusion. But that's making the situation worse. It is causing the heart to have to work harder because we know the periphery is going to vasoconstrict. Remember, angiotensin 1 to angiotensin 2. And we know that aldosterone is going to hold on to sodium water. Now, over time, if that's not treated, the ventricles in the atria will hypertrophy. They get bigger, okay? And that's why I say you've got stretched rubber band, okay? Let me cut my phone off. It's going off all day. There we go. Okay, now. So we know we've got the stretched rubber band with these patients. So in essence, there's, instead of this amount of blood flow, there's this. So there's less going out to the body and less coming back to the body. So when you learn heart failure, you learn that in school, we teach the symptoms of right side and left side. Okay, so you can better understand what is happening to the body. But these patients truly have heart failure. They have left and right side heart failure is what you're going to see in the clinical setting. So as I said, you back up the plumbing. So we know that blood flow comes to the inferior superior vena cava, to the right atrium, right ventricle. Okay, so we're going to back up that plumbing. So what are you going to see in a patient with right-sided heart failure? You're going to see the foot and ankle edema, and then just keep coming up the body. You're going to see that increase in abdominal girth, ascites. You may see hepatomegaly, an enlarged liver, and keep coming up. Then you'll see the jugular venous distension, okay? Now on the left side, back up the plumbing. So the pulmonary vein is sending out blood to the pulmonary system, and then it comes back in pulmonary artery to the left atrium, left ventricles. So if you back up that plumbing, with left side heart failure, you're going to get the pulmonary signs and symptoms, the cough, the dyspnea, shortness of breath, crackles. You may auscultate an S3. But again, you've got to look at the big picture, okay, of what's going on with this patient. So in essence, what am I saying to you guys? Remember in the beginning, I said the pressures on the right side of the heart are low pressures. Pressures on the left side of the heart is a higher pressure system because it has to pump all that blood out to the body. Well, with heart failure, the pressures go up. So preload goes up. And then your afterload, the resistance goes up from the renin, angiotensin, aldosterone system. So now those pressures are higher than they should be. So how are we going to best treat this patient? Well, we're going to hope that we have adequate renal function. And we're going to give this patient, depending on the signs and symptoms, usually by the time they come in the emergency department, they're extremely short of breath. So generally, we're going to give the IV push furosemide, okay? And we're going to monitor the urinary output. Furosemide is the ideal choice because it works within minutes. And we're going to hope they put out a lot of urine. And the respiratory signs and symptoms decrease. Now, we also know that with furosemide, we have to watch out for electrolyte imbalance, especially that low potassium. And that can cause a problem with the regularity of how the heart beats. So we will often give IV piggyback potassium replacements during that time frame. So our goal is to help improve their breathing. Now, we know that this heart failure is not going away. It's not going. It's the patient needs to learn to, again, maintain that low fat, low cholesterol, low sodium diet. You know, send them to heart.org. They can, tons of resources in layman's terms about the DASH diet, the dietary approaches to stop hypertension. Okay, so hold on, I got a question. So with an increase in preload, we're going to see an increase in afterload. Yes, that is correct. Increase in preload on the left and right side of the heart because of the increased myocardial demand and the retention of sodium and water. So the preload is going to go up. In other words, the pressures, what the pressures should be with that very taut rubber band are now higher with the stretched rubber band. And due to renin, angiotensin, aldosterone, the periphery is going to vasoconstrict. So that is increasing afterload.
Ms. Rumpel.
Yes.
Okay, and then vice versa, if there's a decrease in the preload, you'll see the decreased preload symptoms, the poor skin turgor, dry mucous membranes, and the orthostatics.
Exactly.
You'll see the decreased systemic afterload, so the warm flushed extremities.
You got it.
Okay, thank you.
And that's why I pulled up this slide, because you can see how with the increase in preload, it's essentially backing up the plumbing on the right and left side. Decreased preload, you see, that's dehydration. You get the skin turgor, the dry mucous membranes. Essentially dehydration. The body has to have adequate intravascular volume. Too much, that's a problem. Too little, that's a problem. But in reference to our material in heart failure, we're dealing with increased right and left side preload and increased afterload. We also need to think about our labs, certainly our monitoring our eyes and nose, our very closely, our electrolytes, in particular potassium. And another lab they will probably draw is that BNP. That one is used to identify heart failure, as well as chest x-ray as well. So BNP, okay? And we talked about all that. So in essence, you are learning both, but hopefully now you're seeing how it all comes together when you're dealing with patients with heart failure. Often patients with right side heart failure, again, so think about what you would see. You know, I've had patients say, I can't button my collar like I used to, or my shoes are kind of tight now. Well, now and again, it's why those things they may not see as an issue, and they really need to get more objective data like weighing yourself every day, about the same time each day. 2 to 3 pounds in 24 hours, that's a red flag. 5 pounds in a week, red flag. So they may not see that as a problem. You know, they may say, well, you know, I'm more short of breath when I go up the stairs. They may say, well, I'm just getting older. They may not correlate that with the fluid retention. So a lot of education is needed to help keep them at home. But unfortunately, many have to come to the hospital, okay? So all we can do is educate and document our best. That some of these patients, as I mentioned, you know, they may choose not to keep going in and out of the hospital. They just they feel powerless. So, you know, some of them may choose palliative care, others may choose hospice care. But, you know, trying to do their best to take care of themselves and taking their medicines as prescribed and following the appropriate diet and, you know, good follow-up care. These patients can stay at home. They can stay at home, but unfortunately, you know, like I said, low fat, low cholesterol is not a cheap diet. And sodium's in everything. So, you know, it can be difficult. It can be very difficult for these patients. So that pretty much sums up heart failure. What questions might you have about that information?
Ms. Rummel, do you want us to know the alert values for the BNP?
No, you do not need to know. You just need to know BNP is a diagnostic lab draw that we use to indicate heart failure.
Thank you.
Like I said, I've seen them in the thousands.
So is this why, because people with heart failure who experience signs, and I guess they try to blame it on age or their lifestyle, that's why it's diagnosed so when you have heart failure, basically there's, you know, like the stages A, B, C, and D.
Well, and the thing is, you know, those that are diagnosed in stage 1 and 2, we want them to stay in stage 1 and 2.
Okay.
Those that are diagnosed in stage 3, we want them to stay in stage 3. You know, you don't want to see them in that last stage. Because, I mean, you know, that's when For a lot of these patients, you have to talk to them about what kind of outcomes do they really want. If they've gone from stage 2, now stage 3 and stage 4, and that's a process. Don't get me wrong. That doesn't happen, in weeks. That happens over years. But yeah, if they don't take care of themselves, I'll tell you what'll happen. They'll end up in renal failure. And when you can't get rid of your body's fluids, well, think about it. You're between a rock and a hard place then. So it's extremely important. But like I said, you're going to have patients. You're going to have patients that listen and patients that don't. You document, educate, give them handouts. If they, and that's all you can do. That's all you can do. Some patients will listen to you, others will not. Good questions, though. Okay. Now, if you will go to our peripheral disease. That was our last topic. Okay. Now remember, with these summary points, you will see a term that says peripheral vascular disease. That's like this umbrella term for arterial and venous insufficiency. The best way to learn this, as I mentioned, is look at peripheral arterial disease and peripheral venous insufficiency, okay? So pretty much I think you've got now who's at risk, okay? Those wonderful risk factors, although, modifiable and non-modifiable. So, risk factors have huge impact on our cardiovascular system. So we do know with peripheral disease that smoking and diabetes are huge. They play a huge part in peripheral disease. So when you're looking at signs and symptoms of that peripheral arterial disease.
Mrs. Rumble, may you share your screen, please?
I'm so sorry, I forget. Was that what you put in my chat? Yes. Okay, so remember with peripheral arterial disease, the arteries send blood out to the body. So if the arteries in the periphery are narrowed, let's say our patient, has hypertension, smoking, diabetes, and doesn't really do a good job of taking care of themselves. So over time, those vessels narrow. And then you've got decreased blood flow, just like we saw with the coronary vessels. Plaque buildup, platelets adhere, the lumens narrow, and you've got a mess. So your signs and symptoms will be based on the extent of how narrow are the vessels. We know that one hallmark sign of arterial disease is pain, that's intermittent claudication, especially with exercise. And usually it resolves with rest. But again, in that patient that's not doing a good job of taking care of themselves, eventually those vessels are going to continue to narrow and they could have pain at rest. So this is when we are looking at pulses. Remember, if you cannot palpate a pulse, you get a Doppler and auscultate to see if this patient has any type of blood flow to their periphery. And so with that, they could have muscle pain. It just depends on the extent of the disease. So what are we going to do for this patient? Well, we're going to do our obvious assessments, for looking at perfusion, pulses, etc., in our periphery. And then with our peripheral arterial disease, you remember I said, look at the A for artery. Their legs should go down. Okay, so we're going to encourage them. Keep their legs, they can sit with legs on the floor. Don't cross your legs. You can dangle them off the bed, etc. Okay. Now, something that we as nurses have to look out for, the worst of the worst. When I cannot hear a pulse, that is very, very concerning. Okay. Physicians should be notified. And they're probably going to do like a Doppler ultrasound, color imaging. They're going to see exactly how much flow is going to that foot. So, no Doppler pulse, cold, delayed cap refill. That means there's a lot of occlusion there. And of course, we don't want the worst to happen, which is the patient lose toes. And if you remember with arterial disease, our goal would be now they actually can go in and do the balloon and put stents in. And that patient will be on antiplatelet therapy. But even if they are not at that point, let's say they have a Doppler pulse, you still have a pulse in this patient. They should be on some type of antiplatelet therapy to help blood flow to move more freely to the periphery. Okay. So again, that is what you would expect. If, again, the patient does not seek medical advice and doesn't take care of themselves, they will develop ulcerations on like the top of the toes or right in between the toes. Okay. And the worst would be it could become infectious and they could lose a toe. So those are things you don't want to happen. So our assessment findings are critical, as always, with our patients. That's what we do. Okay, your antiplatelets. As I said, we're always educating and documenting. But we cannot always change what people do. All right, now if you remember with venous insufficiency, okay, the veins bring the blood back to the heart. Now with venous insufficiency, you have venous pulling, venous stasis, and injured vessel walls. And you will also, you'll probably, if you hadn't seen them, you see the enlarged veins. Okay, a lot of people have that with the venous insufficiency. So, who's at risk? Well, we know patients with atherosclerosis, in particular smoking diabetes, but certainly patients after surgery or on long-term bed rest are at risk, in particular those with venous insufficiency. We become very concerned. Large bone surgery, obesity, pregnancy, and contraceptives can lead to a DVT, and that is something you do not want. So now the big push is anticoagulant therapy. prevention is huge now with DVT. DVT prophylaxis. And like I said, in Joint Commission accredited hospitals, you will see the venous thromboembolism core measures in place, meaning that if you fall into an at-risk category, they will probably start you, unless it's contraindicated, like a GI bleed or something like that, then they'll probably have you on sub-Q heparin. So we want to enhance the flow of that blood back to the heart. So that's where our TEDs, our white hopes, our SCDs, and again, if you remember V for vein, we're going to elevate the feet above the heart, elevate the feet above the heart, above the level of the heart, to let gravity enhance that return.
Ms. Rumble, I have a question.
Yes.
Okay, with the DVTs, I understand that we're supposed to let them rest, but if we're using TED hose on there, will we be helping them assist to move that clot and if it can cause embolism, or do we still use the TED hose?
If you're talking about a patient, you mean a patient diagnosed with a PE? Now, those on DVT prophylactic prevention, they need to get up. But a patient diagnosed with a PE will be determined by the size of that PE.
Okay.
Yeah. No, prophylactic prevention for DVT, we want them to get up. We want them to move. Get that blood flow circulating while you're in bed. Use your SCDs. We're going to give you that 5,000, sub-Q heparin twice a day, or enoxapril, Lovenox twice a day. Because our goal is prevention. The biggest problem with deep vein thrombosis is a natural clot, or a pulmonary embolism. A pulmonary embolism can kill a patient if it's of significant size. So that is why this prevention is so important. So we're gonna, with DVT prophylaxis, we're gonna be implementing all of these interventions to help prevent them from developing any type of thrombosis. Patients with long-term venous insufficiency, like I said, will have edema due to the venous stasis and pulling. Their veins may be enlarged. Their skin color can turn kind of a brownish skin color due to lack of blood going back. And their ulcerations are generally on the ankles or bottom of the feet. Okay. And depending on how well they take care of themselves will determine, if they get any ulceration. But those that truly, they won't stop smoking, or, they don't want to take care of their diabetes. And this is, of course, over years and years. And we know with diabetics, you learn that early on, the importance of foot care. Well, this is just now another layer to a hot bed. Some of these ulcerations can be very long-term ulcerations. Some of these patients end up going to a wound clinic to prevent or treat infection. Because your goal is you never want to see them lose toes due to this. So there's all types of treatments out there for these wounds. I'm not going to go over that. That is when you need to get If it's a new wound, you need to get wound care involved. So again, with DVT prevention, you know, we do get them up, try to promote circulation. That's what I'm trying to say. Okay, now this is the big complication that could be life-threatening. And it depends on the size of the clot. A pulmonary embolism, again, I've seen it kill patients. What you will see is a patient whose oxygen level drops very quickly. And they look like, I mean, you ever see people who look like, you know, they can't breathe. Some will say they have a sharp pain. Can't breathe, sudden dyspnea. So that demands your direct attention because, like I said, we don't know the size of the clot until they get an angiogram. So during that time, you are, of course, putting oxygen on the patient. You stay with them, try to keep them calm, and you're anticipating orders for a heparin bolus and a heparin drip at this time. So that is initially to prevent more clots from forming. And then over time, hopefully as the patient stays in the hospital with the heparin IV drip treatment, that clot will start to dissolve. So again, sudden onset of dyspnea. And these are things you should always be watching out for. Like I said, in your patients that are on DVT prophylactic prevention, because they could have clot. And so once we get our scan, then the physicians will know the size of the clot. And we're going to start that heparin, give a bolus and a drip. And you'll learn all about that in 213. Now, the key right now is when you give your heparin bolus and drip, you're going to monitor your PTT. You want that 1.5 to 2 times the normal. So if the initial PTT is, say, 30 seconds, then you want that PTT. You're going to recheck it in like 6 hours, and you want your PTT to be like 60 seconds. So you want it 1.5 to 2 times the norm. So think about it. You don't want your PTT below 30, right? That means they're going to clot. But you don't want your PTT above 60 because that puts them at risk for bleeding. So it's very important to make sure that the PTT is 1.5 to 2 times the norm. Now, as we talked about last time, as our patient is preparing for discharge, the physician will order, let's say they order warfarin, 10 milligrams to be given by mouth at 6 o'clock. So we are going to go ahead and give that warfarin because we know that heparin has a short half-life, where warfarin has a long half-life. So we know it can take 2 to 3 days for the warfarin to be therapeutic. Now with warfarin, we want our INR to be 2 to 3. So if its INR is 1, they're at risk for clotting. If INR is 4, they're at risk for bleeding. And we want our PT to be 1.5 to 2 times the norm. Patients who are candidates may go on the new oral anticoagulants. And you would just start those as well, okay? And then shut your heparin off. Okay, so we have to make sure that those levels are therapeutic. So the patient, if it's too low, patient will clot, too high, patient will bleed. So you have to be monitoring that, okay? So as I said, our big thing is DVT prophylactic prevention. Hopefully you won't see a PE because PEs can kill people. And unfortunately, I have seen that. So that's why, with the safety core measures, that's been a big push, that people should not die because they're at risk for DVTs. And, monitoring our heparin therapy, get them on that oral anticoagulant. Of course, with warfarin, they're going to have good follow-up care. And even with the new oral anticoagulants, those patients need good follow-up care. And so they can live very long, normal lives. Okay, so any questions about that? Okay, so what we're going to do, we're going to take a 10-minute break. When we come back, I'm going to go over your clues. Okay, the clues. And we'll go over that. That's going to be a nice little review. And then I'll take any questions. Okay, so take about a 10-minute break. Okay, we're recording. Okay, I have a question that said, is there anything else about cardiac cath that we need to know other than what you stated last week? Well, let's review cardiac cath. First of all, as a nurse, if your patient is going for cardiac cath, you need to know if they have any allergies to iodine or shellfish. You also would need to assess their creatinine level. If it's 2.0 or greater, that should be conveyed to the cardiologist or the cath team. We know that cath dye is eliminated via the kidneys. So if they already have some type of renal issues, then they need to be aware of that. So cath dye, the patient gets adequate fluids to try and eliminate that cath dye, okay? Now, we also know that depending on what they do, we're going to be watching the insertion site. That could be femoral, it could be the radial, but we're going to watch that insertion site for any outward or inward bleeding, and we're going to make sure we assess perfusion below that insertion site, making sure we have adequate perfusion, okay? Remember, in cardiac cath, they get antiplatelet therapy back there, IV drips. They even get heparin back there. So it's very, very important that we watch for any signs and symptoms of bleeding and impaired perfusion to that periphery, distal to the insertion site. As long as they do okay, they'll come out. We know if they got stents, they're going to be on an antiplatelet. So the big thing with the using the femoral site, remember they have to keep their legs straight. Usually that's about 6 hours. So that can be very difficult for some of our patients. One of the biggest complaints that we get is back pain. So that pretty much, I think, summarizes cardiac cath. And making sure you're protecting your patient. Okay, our last little bit of review here. All of you should see the clues on the screen. So again, this is just to really help jar your memory about the content. As a nurse, you should be asking yourself, what signs and symptoms do I see? Who's at risk? And how do I intervene to make a difference for these patients? Okay. So we have Joe. Joe has a history of, so this is to to get your brain going about modifiable risk factors. So we could do diabetes, smoking, hypertension. You could put in there obesity, advanced A, and not obese, sedentary lifestyle. So any of those you could put in there. Okay, hold on. So somebody's asking, is there an actual answer key to this? No, but I can make one. Okay, I made this up. So I can put the answers in if you want me to. Okay, so his non-modifiable risk factors, that could be age, that could be genetics, that could be ethnicity, male gender. He has increasing pain with moderate activity. This is called angina. Angina is chest pain. So let's give him stable angina. So rest, remember, and or nitroglycerin relieves stable angina. He goes to the doctor. His blood pressure that's a stage 2 hypertension. The doctor puts him on a Pril. So a Pril is an ACE inhibitor. Is anything from here going to be seen on the test? Well, yeah, this is a whole summary of what you're going to see on your exam, okay? So the doctor puts him on a Pril, okay? So we know those are ACE inhibitors. Well, what did you learn about ACE inhibitors as a nurse? What do you need to do? What do you need to think about when patients are on ACE inhibitors? Okay, so let's put him on lisinopril. So see, it's to jar your thinking and not just about, oh, Prils are ACE inhibitors. Well, you remember on those drug cards, I said on the back, you have to know, what did Ms. Rumble say? A nurse needs to know about this medication, okay? And a thiazide diuretic, which we know that often HCTZ, hydrochlorothiazide, can be given with an ACE inhibitor to help balance out the fluid and electrolytes. The doctor recommends, he's definitely needs, with risk factors, he's going to need a low fat, low cholesterol, and low sodium diet. And we know he should watch his sodium intake. He takes his meds, but says he feels tired. And that is not uncommon when they first start taking their meds. He stops the medication. Joe is at work and complains of angina at rest. So that is unstable angina. Remember, unstable angina is not relieved by rest and or nitroglycerin. So the coworker calls 911. Joe has pain. Let's say he has other signs and symptoms. Let's say he has shortness of breath and he's diaphoretic. When the medic arrives, they administer oxygen. This is to jar your memory about interventions with the pneumonia, okay? So we're going to administer oxygen. They also administer nitroglycerin sublingual 1 tab every 3 to 5 minutes times 3. And a chewable aspirin to prevent that platelet aggregation. Joe continues to complain of pain, so they administer the morphine IV push. His EKG shows, now this is something you'll learn in 213, ST elevation. You'll learn about STEMI and non-STEMI in 213, so that is not on this test. Joe goes straight to the cardiac cath lab. Now again, that's to jar your memory into saying, do I really know how to take care of a patient going to the cardiac cath lab? Okay, you just don't fill in these little boxes. In the cath lab, he has 2 vessels occluded, his RCA and his left circ. So he has the PTCA, the balloon angioplasty performed with stent placement. And of course, with his pain, chest pain, we wanted to know if his troponin lab value is elevated. If his troponin lab value is elevated, he's probably had a myocardial infarct as well. And that's irreversible. Okay, the medication he will be on, remember with stent placements, they need to be on dual antiplatelet therapy. So like an aspirin and a clopidogrel. He continues the ACE inhibitor, his lisinopril, and returns to work. Wait a minute, hold on. Oh, he continues the lisinopril and they add a beta blocker. So again, we know that's an OLAW. What does Ms. Rummel say? A nurse needs to know about an OLAW. So let's put him on metoprolol. Joe returns home 2 days after the cath. He returns to work and he's feeling good. He does not like the beta blocker. The beta blocker, the side effects for beta blocker, they can make you feel tired, fatigued, and they can also affect men by causing erectile dysfunction. So the doctor puts him on a calcium channel blocker. Well, as a nurse, you need to know the calcium channel blockers. What do they do for the patient? Et cetera, et cetera. He continues to have a dry cough and he's tired of this, which we know ACE inhibitors can do that. So the physician stops his lisinopril and puts him on a sartan, an ARB. So we'll put him on losartan. He carries nitroglycerin in his pocket for any chest pain. Joe has a hard time with his diet. A lot of patients do. He cancels his follow-up appointments with the physician, afraid he will add another medication. Joe is at work and has chest pain. His coworker calls 911. So in the hospital, Joe is given a diuretic, furosemide IV push. So now he has gone from a tight rubber band to a stretched rubber band. He's not taking care of himself. His cholesterol is elevated. Remember, we want less than 200. His ADL is less than 60. We want greater than 60. His LDL is less than 100. We want his LDL, is greater than 100. We want less than 100. And his triglycerides are greater than 150. So he is definitely showing he is not taking care of himself. So he is started on a statin. Okay, Let's put him on atorvastatin. Again, what did Ms. Rummel tell you to learn? That a nurse needs to know when a patient is taking a statin. Okay, you have got to know that information. Due to the effects of the diuretic, Joe's labs show, remember, furosemide, you're going to lose potassium. So now he has hypokalemia. So he is given potassium replacements. Joe returns home on several medications. 6 months later, Joe is feeling tired. All right, he sleeps on 2 pillows. He is short of breath. Well, that's left side heart failure. At the physician's office, the doctor auscultates an S3. He's placed on this diuretic, probably furosemide by mouth. He continues to work. He has edema in his feet. So there you see it. Now this man has heart failure. Okay, he has not taken care of himself and followed physician's orders, and he's got heart failure. So this indicates right side heart failure. He continues to take his meds. At work, his legs are painful with walking. So now we know, because he's not taking care of himself, he's affected not just his heart, but his periphery. Yes, thank you for reminding me. There we go. His periphery. So now this is called intermittent claudication. So we know he's got peripheral arterial disease. And again, you guys have to say while you're studying, what did Ms. Rummel say? I need to learn to be a nurse taking care of a patient with peripheral arterial disease. Due to peripheral arterial disease, Joe fell at work and broke his shoulder. He is hospitalized for shoulder surgery. To prevent clots post-op, Joe wears, let's put him on SCDs. He is sitting in the chair. First day post-op, he becomes very anxious and he's in trouble. His O2 sat is low. He feels short of breath, and he's now diagnosed with a PE. So he started on a heparin drip, and as we reviewed today, you want his PTT to be 1.5 to 2 times the normal. After 3 days on heparin, they start him on warfarin. His INR needs to be 2 to 3, and his PT needs to be 1.5 to 2 times the normal. He continues with his multiple meds. He enters the hospital 3 months later. He cannot breathe. His BNP is elevated. He's in and out of the hospital with his heart failure. So he's placed on what, 100% non-rebreather, maybe. He is giving furosemide IV push so he will urinate. A Foley is inserted. Now, see, this is what happens due to the fact that he did not take care of his health and follow physician's orders. Now his bun is going up and his creatinine is elevated. So now he's having difficulty getting rid of fluid volume. So they have to intubate him, put him on a ventilator, and send him to the unit. And that is something patients do not understand. A cardiac issue can lead to so many problems in the body, such as kidney injury. And you see it a lot. Okay, so that was an overall review. Again, as you are looking at your resources, again, there's the Swift River, cardiac bingo. You can cut up the questions, cut up the answers. I always say, try to do some matching with that, but mix up the questions. And even with this, guys, it's not about filling in the blanks. It's about, what have I learned that I need to know to identify and treat these patients as a nurse? And that requires critical thinking, okay? And that's nursing school. So, do you have any questions?
I have a question.
Yes.
I'm not really confused about the control of the heparin, but I am confused a little bit with the PTT, because we elaborated last week by looking the level up, which is 25 to 35. And you're saying that the PTT needs to be 1.5 to 2.5 times the control. So help me out with that. So like,
okay. So let's say, okay, so your patient is Joe. Mm-hmm. So Joe now needs to start on his heparin. So you do that initial blood draw, and his PTT is, let's say, 25. So you give him a heparin bolus and you start a heparin drip. Okay. And then 6 hours later, you see that his PTT is 30. Well, that's not enough. So you check it 6 hours later and you see that his PTT is 50. So that is 2 times the norm of the original 25 seconds. Does that help?
Yes, that helps better that you explain it that way. Thank you. Mm-hmm.
Anything else? I will put up an announcement tomorrow. You will be able to download your test tomorrow afternoon. And if you have no more questions or something comes up, just send me an email, and I'll get those invites out for whoever I'm proctoring. And if not, I'll see you on Wednesday. Y'all good?
Thank you.
Okay, you take care. I'll get this stuff up a little bit later, but I will get it up.